I'm Steve Walker, and I'm with Fleischman Hillard International Communications. And on behalf of bioMérieux, I'd like to welcome you all to the first in a series of 3 webinars designed to educate clinicians involved in sepsis management on the role of procalcitonin. Our webinar today is going to focus on the critical care physician's perspective and will be led by Dr. Devendra Amin. Dr. Amin is Assistant Professor of Medicine in the Department of Family Practice at the University of South Florida and Medical Director of Critical Care Services at Morton Plant Hospital in Clearwater, Florida. Dr. Amin has authored numerous scientific papers on respiratory health and has significant experience with procalcitonin in his institution. So for the next 35 or 40 minutes, Dr. Amin will share information about procalcitonin and how it can help take the guesswork out of early treatment decision for your suspected sepsis patients. I'll turn it over now to Dr. Amin to begin our presentation today. Dr. Amin?
Thank you, Steve, for the introduction. Good afternoon, everybody. Thank you for joining us. The next slide is going to demonstrate a few disclosures as a consultant and speaker of bioMérieux and speaker for Axilium. We've been using procalcitonin in Morton Plant Hospital now for about 18 months. The hospital is a 450-bed non-profit hospital, part of a 4-hospital system, which is part of a 9-hospital regional system. And we introduced procalcitonin to help us with our sepsis protocol. And I think we've been using it to good effect. I'd like to share some of that experience over the next 45 minutes or so. Sepsis is a major problem nationally and internationally, as you're all aware. It's a systemic inflammatory response to infection. Its incidence is increasing. It's the 10th leading cause of death in the U.S. It's a very common cause of progressive organ dysfunction. It impacts on the cost of care and increased length of stay. The incidence is on the rise because of increasing number of elderly patients, increased use of invasive and diagnostic procedures, increased use of immunosuppressive and cytotoxic agents, increased number of immunosuppressed patients. Bacterial resistance is becoming a larger problem, and there's an increased awareness of the problem, too. If you look at this graphic, looking at the incidence, looking at the y-axis on the left, the incidence per 100,000 is increasing through time and through age. If you look at the mortality rate, as we get older into the 4th and 5th decades of life and onwards, the mortality rate goes up almost exponentially as opposed to the almost linear increase in incidence across age. So it's a significant and progressive process in life. If you look at the incidence when compared to other major diseases, severe sepsis is seen in approximately 300 per 100,000 of the population. In children, it's 20 per 100,000. And in the above 85-year-old group, it's 2,650 per 100,000. Clearly a major impact on hospitalized patients. Compared to breast cancer, colon cancer, and AIDS, all significant in their own way, but numerically not as many. Graphically, if you compare the incidence of severe sepsis with congestive heart failure in cases per 100,000, breast cancer, colon cancer, and AIDS, it is clearly a major problem. And these are from 2001 data from a large study produced by Angus and his colleagues at the University of Pittsburgh. Similarly, from the same study, looking at the mortality of severe sepsis, it's very high, as high, if not higher now, than what we see with acute myocardial infarction. As the progression of disease goes from SIRS, sepsis, severe sepsis into septic shock, the mortality rate increases. As you see, the mortality rate in the graphic there, ranging from 7 to 10% up to 46% or higher with patients developing septic shock. Similarly, as the number of organ failures increases, the mortality rate increases from less than 15% if it's a single organ failure or less, or to 70% or more if there are 3 or more organs involved. The other information from this particular slide shows that ICU admission after the onset of sepsis produces a much higher mortality rate in excess of 45%, but if you happen to get to the ICU before the onset of sepsis, the mortality rate is somewhat lower. So the incidence is significant, 2 to 5 per 1,000 hospital patients, 3 to 5% of medical ICU patients, and 9 to 16% of all surgical ICU patients. This is from data in 1995 to 1997, and also from Dr. Angus's data that we saw earlier in 2001. The mortality rate overall hasn't really changed in the last few decades. It ranges between 30 and 50%, It's the main cause of death in the non-cardiac ICU. The 1995 costs were about $22,000 at that time, is now approaching $35,000 per patient at this time in 2008-2009 figures. This Venn diagram shows the relationship between inflammation, severe inflammatory response syndrome, infection, and where there's an overlap, you may have sepsis or severe sepsis. Clearly, there are other reasons to develop SIRS symptoms, ranging from burns, trauma, or pancreatitis, or other injuries. So the initial presentation can be somewhat blurred as to what's actually causing the problem before you can actually home in on the diagnosis of severe sepsis. However, some of the definitions in SIRS and the SIRS criteria, you're probably all aware, it basically is a temperature elevation or reduction from normal, tachycardia, tachypnea, as well as leukocytosis or 10% or more immature or band forms. Sepsis is SIRS plus infection. Severe sepsis is sepsis plus organ dysfunction. And septic shock is seen in severe sepsis with persistent hypotension despite adequate fluid resuscitation. So what makes the problem so difficult? SIRS criteria are very nonspecific and present in many patients independently of sepsis. Microbiological proof of infection is often negative and the availability is delayed. This results in overprescription of antibiotics and possibly extended duration of antibiotic treatment, resulting in development of antibiotic resistance, nosocomial infections, and increasing cost to the system. Overall, severe sepsis is underdiagnosed, and sepsis can occur throughout the institution. The historical focus has been on supporting failing organ systems rather than on identifying the underlying disease. There's no clinical definition that can be applied at the bedside, and really there's no single test or marker that we have to define sepsis. And the patient population is heterogeneous. Patients come into the emergency room, with various different symptoms and signs, and don't often say they're septic. So it can be very difficult and challenging diagnosis to make initially. This one study that I'd like to share was published in Critical Care Medicine 2006, published by Kumar et al. And really what they saw with this study was, what they looked at was to look at the effectiveness of antibiotic therapy in patients and the timeliness of antibiotic therapy in patients who were defined as being hypotensive on arrival. It was a retrospective cohort study performed between July of 1989 and June of 2004, involving 14 intensive care units, 4 medical, 4 surgical, 6 mixed medical surgical units covering 10 hospitals, some academic, some community, involving ICUs in the United States and in Canada. They reviewed 2,731 charts with adult patients in septic shock, with no interventions. What they found was that effective antimicrobial administration within the first hour of documented hypotension was associated with increased survival to hospital discharge in adult patient septic shock. Despite a progressive increase in mortality rate with increasing delays, only 50% of septic shock patients received effective antimicrobial therapy within the first 6 hours of documented hypotension. This graph clearly shows the significance of this study. If you received antibiotics in the first hour, your survival rate was significantly improved at 78.9%. If you delayed treatment with antibiotics, for every hour of delay, the mortality rate went up by 7.6%, or survival decreased by that amount. The median time to effective antibiotic delivery was about 6 hours in this review, and the 25th to 75th percentile numbers were between 2 and 15 hours. So this brings home the point that early diagnosis, early intervention is key to survival. So for every hour's delay in diagnosing and administering antibiotics, the mortality rate goes up by 7.6%. Quite an incredible number. We're all aware of the golden hour when it comes to trauma. Clearly this applies to sepsis as well. So what do we have right now? The biomarkers of infection that we use right now are essentially gram staining, cultures, which are only positive about 30% of the time. They take hours or a couple of days to come back. We use white cell count, CRP, and a newer reagent that we have with procalcitonin. We also have global indicators of tissue perfusion to help with confirming the diagnosis. We look at serum lactic acid. We can look at mixed oxygen saturation. And all these help guide in our early recognition and management of sepsis. Perhaps this was best summed up by Roger Bone past president of the Society of Clinical Medicine and CHEST, saying rather than trying to find the magic bullet to cure sepsis, maybe the focus should be on early recognition. So what is the ideal biomarker? The ideal biomarker should be objectively measured and be reproducible. It should be an indicator of normal physiologic processes, pathogenic processes, pharmacological response to therapeutic intervention. It should reflect the underlying biological process, predict clinical events, should be easily obtainable, reproducible, and affordable. Procalcitonin was FDA approved in the United States in 2008 and is intended for use in conjunction with other laboratory findings and clinical assessments to aid in the risk assessment of critically ill patients from their first day of ICU admission to progression to severe sepsis and septic shock. The SCCM guidelines, the Society of Critical Care Medicine guidelines for fever evaluation published in 2008, showed that there was a more sensitive serum procalcitonin assay now approved for the early detection of bacterial infection and sepsis in patients during their first day of ICU admission. Viral infections, recent surgery, and chronic inflammatory states are not associated with a significant increment in procalcitonin levels. In 1993, it was shown that there was a strong correlation between serum procalcitonin levels and bacterial infections. It's a sepsis-induced plasma protein. It's induced primarily by severe bacterial infection, and procalcitonin, calcitonin, catecalcin fragments measured by antibiotic binding, as with the LUMI test or the PCT test now available, is how it is measured. It's a complex amino acid chain of 116 amino acids. It's encoded by the calc gene 1 on chromosome 11, producing calcitonin, procalcitonin 1, and procalcitonin 2. The biological function of PCT is probably no longer clinically relevant. It seems to be a vestigial molecule, but as it has a minimal effect on calcium homeostasis, it may modulate endotoxic shock. High levels suppress TNF-alpha, and high levels have a pro-inflammatory effect. In health, procalcitonin is produced by the C cells of the thyroid gland. In septic states, multiple organs produce procalcitonin, primarily from circulating monocytes, hepatic cells, and hepatic monocytes. The production of procalcitonin is limited in health, but it comes from multiple organs in sepsis, as you can see from this gastromatograph on the right. So procalcitonin is cleaved intracellularly, hence serum levels are very low, but during severe infection and sepsis, procalcitonin plasma levels may increase to over 200 nanograms per mil, normal levels being less than 0.05 nanograms per milliliter. This increase in procalcitonin is not accompanied by an increase in plasma calcitonin levels. Procalcitonin has a half-life of 25 to 30 hours in the bloodstream. You look at this graphic showing the release of these various inflammatory mediators following an endotoxin challenge in human volunteers. See, IL-6 and IL-10 go up fairly rapidly, as does TNF-alpha. PCT takes about 2 hours to start increasing in levels, but then starts to drop down fairly rapidly once the endotoxin is removed. CRP lags in its elevation and lags in its decline despite clearance of the endotoxin. In about a 24-hour period, the PCT levels usually come down by about 50% in the setting of normal renal function. This is a composite of several studies looking at the sensitivity and specificity of procalcitonin in red and CRP in the yellow. PCT pooled sensitivity in this group of studies is about 88%, and the pooled specificity was 75%, looking at the summary receiver operating curves. This came from a study published in Critical Care Medicine in 2000, looking at the calcitonin precursors compared to CRP, IL-6, and lactate as markers for sepsis. The calcitonin precursors sensitivity on this study was about 89% with a specificity of 94%. The negative predictive value was 90% for procalcitonin, and the positive predictive value was 94%. Clearly superior to CRP and lactate. IL-6 is not really commercially available for everyday use. This next study, again published in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine in 2001, looked at the utility of procalcitonin, and in addition to the clinical model of defining sepsis using the same definitions as we looked at earlier. The graph on the left-hand side looks at the receiver operating characteristic curves of plasma PCT, interleukin 6, interleukin 8. You can see with that, using a cutoff level of 1 nanogram per mil for procalcitonin, the sensitivity was 97%, the specificity was 78%, somewhat better than interleukin 6 and interleukin 8. On the right-hand side, you look at the graphic showing the sensitivity and specificity of a clinical model with PCT in the upper curve compared to the clinical model without PCT in the lower curve. So if you just look at the clinical model, your sensitivity and specificity is significantly less, of 0.77, but if you add to that procalcitonin, sensitivity and specificity was significantly improved in helping diagnose septic patients. If you look at the levels of procalcitonin from the same study, there's a range, but you can see it's an increasing range on a logarithmic scale, comparing SIRS to sepsis, severe sepsis, and septic shock, where the numbers can be extraordinarily high in seriously ill patients. The kinetics of PCT are interesting as well and can be very helpful, I think. This shows the effectiveness of treatment. If you follow the red line, oftentimes you'll see a little increase in the first 24 hours, and then as you get an appropriate response to antibiotics, the procalcitonin level comes down nicely. And then in the black line, you see a lack of response or lack of reduction in procalcitonin until there's a therapeutic change, and then the level comes down. The yellow line would suggest a therapeutic failure and worsening procalcitonin and worsening prognosis. This next graphic is interesting in that it shows patient survival. If you look at over time, if you look at the yellow curve, that applies to patients who had a low or decreasing procalcitonin over time, which had a much better patient survival than if your procalcitonin was high and increased over the few days of monitoring. So if the procalcitonin is responding, or if the patient is responding to treatment, you should see a commensurate reduction in procalcitonin, which would imply an improvement in survival compared to an increasing procalcitonin during therapy. And that was very significant, p-value of 0.0001. Looking at this another way, the same study, a high maximum procalcitonin and a procalcitonin increase for 1 day are early independent predictors for all-cause mortality at a 90-day follow-up period. As you can see, a significant mortality rate as the procalcitonin goes up by day 3 of 72%, versus if the procalcitonin was starting to come down. Again, very significant difference. So what's available right now? The earlier generation of procalcitonin testing available in Europe was using the Brahms PCT ELISA test. We now have a more sensitive test, the Cryptor test, as well as the Vitus Brahms PCT second generation assay, which provides ELISA technology with a 20-minute turnaround test. We use a stat test for some of our ER testing, as well as batch testing for morning testing that we do on a routine follow-up basis. And it has a lower level of sensitivity at 0.05 nanograms per mil for patients who at the 95th percentile. At the normal PCT level, the 99th percentile would be at 0.09 nanograms per mil. In a therapeutic setting, if the procalcitonin level is less than 0.05, you'd assume that to be a normal level. And if it's less than 0.5, then you'd expect possibly a local infection. Once you start getting between 0.5 and 2, you're probably going to be seeing a systemic infection, inflammation developing, and above 2, manifestations of severe sepsis, and then above 10, patients probably having symptoms or signs consistent with septic shock. The next slide looks at the biological variability of what happens in different tissue or different organs are affected and infected. Looking at this table from Meissner's article from 2002, you can see that looking at the difference between bacterial and viral meningitis using a cutoff of 1.8 nanograms per mil, they had 100% sensitivity and specificity. Different studies looking at different cutoff levels showed different sensitivities and specificities. The bacterial versus viral pneumonia using a cutoff level of 2, that particular study, it was a sensitivity of 63% and specificity of 96%, and so on, looking at pancreatitis, septic shock, and invasive versus local bacterial infections. So even though we see a significant elevation of procalcitonin with bacterial infection above normal, different tissues that are infected can have different levels of activity and elevation of procalcitonin. And it's still to be discovered at what level different infection in general will give you to what degree of an elevation you would see. So procalcitonin, I would think, is a novel marker for clinically relevant bacterial infection and sepsis. Elevated levels are highly suggestive of bacterial infections with systemic consequences. In septic conditions, increased procalcitonin levels can be observed within 3 to 6 hours after an infectious challenge. Procalcitonin levels are usually low in viral infections, chronic inflammatory disorders, or autoimmune processes. Procalcitonin development reflects the progression of disease from sepsis to severe sepsis and ultimately septic shock. And procalcitonin potentially has a substantial impact on therapeutic decisions and healthcare costs. Because of the rapid decrease resulting from a half-life of about 20 to 24 hours, reduction in levels would reflect effective treatment, as you'd expect it to come down by about 50% every 24 hours. There are some limitations of procalcitonin, like in any other test. There are some false negatives seen with early infection, sometimes with localized infection, and subacute bacterial endocarditis. There are also some limitations with false positives, often seen in the newborn, in severe inflammatory states such as ARDS. I've seen this develop with chemical pneumonitis, falciparum malaria, systemic fungal infections. So I'm not sure I'd call that a false positive, but it's a manifestation of a fungal infection. Trauma, infusions with anti-thymocyte globulin, burns, pancreatitis. Medullary thyroid cancer as well as metastatic small cell cancer can also elevate procalcitonin levels, as well as TNF-alpha infusions, and sometimes apparent neoplastic hormone secretion. But with those conditions, you generally don't see the spike that you see with infection, and you don't see the response you see with treatment, and tends to be more of a level elevation of the marker rather than a elevation and reduction with treatment that you see in a septic or infectious state here. One of the clinical studies that's come out more recently, which I found interesting and thought would be good to share, was the study in the American Review of Respiratory and Critical Care Medicine, and using procalcitonin to shorten antibiotic treatment duration septic patients. The same algorithm has been used in other studies, as you may know, in pneumonia and lower respiratory tract infections, bronchitis. The same kind of process was used for these patients to see if an algorithm based on serial measurements of procalcitonin allows for reduction in duration of antibiotic therapy compared with empirical rules, and to see if it resulted or not in more adverse outcomes or so. So in this study, there was an intervention group where antibiotics were stopped when PCT levels had decreased in 90% or more from the initial value if the clinicians agreed, but not before day 3 if the baseline PCT levels were less than 1 nanogram per milliliter, or day 5 if PCT levels were less than 1 nanogram per milliliter, that should read. In the control group, the clinicians decided on duration of antibiotics based on empirical rules. Patients were assigned to the PCT group had a 3.5-day shorter median duration of antibiotic therapy with a p-value of 0.15. Procalcitonin guidance resulted in a 4-day reduction in duration of antibiotic therapy per protocol, p-value of 0.003, and a smaller overall antibiotic exposure with a p-value of 0.0002. There was a similar mortality and recurrence rate of the primary infection observed in the PCT and the control groups, and overall a 2-day shorter intensive care unit stay was observed in those patients whose therapy was guided by a reducing procalcitonin, again significant. Excluded from the study were infections that were identified and were usually treated with a much longer course of antibiotics, such as Pseudomonas, Acinetobacter, and those that you can see listed there. Patients with bacterial endocarditis, deep abscesses, brain abscess, etc., were again situations where you treat for much longer and were not in the protocol. Also, patients who had antibiotic therapy started more than 48 hours or more prior to enrollment were excluded, and patients with known chronic localized infections. Severely immunocompromised patients, patients on immunosuppressive therapy, and those who had life support withheld or to be withheld were excluded from the study. If you look at the rate of decline of procalcitonin, it seemed to be the same in both groups, which is typical of what you see with appropriate therapy in most of the patients. On this graph, you see that the PCT-guided group showed significant reduction in antibiotics at day 7 and 10 compared to the treatment as usual control group. On this table, what you're seeing is the difference between the control group and the procalcitonin group, and the relative difference or mean difference. And really the most significant changes are in the total antibiotic exposure and in the ICU length of stay. Of note, there was not an increased relapse rate and or adverse outcome if you were guided by procalcitonin versus standard of care. In conclusion to this particular study, an algorithm based on serial PCT measurement allows for more judicious antibiotic use in patients with severe sepsis and septic shock. There's reduced antibiotic exposure, reduced lengths of hospital and ICU stay, no difference in the 28-day mortality, clinical cure, and infection relapse rates were observed, and they recommended a multi-center trial enrolling a large number of patients with severe sepsis and septic shock to test the PCT guidance protocol and its effect on ICU length of stay to validate the data. Summarize that, the results would suggest that a protocol based on serial PCT measurements allows for a reduction in antibiotic treatment duration and exposure in patients with severe sepsis and septic shock without apparent harm. To summarize what we've been through so far, procalcitonin, the 116 amino acid precursor peptide of the hormone calcitonin, has about a 20 to 24-hour half-life. It may modulate septic shock. It may have a pro-inflammatory effect seen in animal studies. It has a theranostic value, I believe. There is now a rapid turnaround test using the Vitus ELISA test, and measuring the PCT for clinically relevant bacterial infection and sepsis is possible now, which may help in risk assessment in the ICU and emergency room, and it's felt to be useful in determining efficacy of treatment and also in ruling out viral infection. Potential utilities are helpful in early diagnosis, risk assessment, prognosis of disease, and probably help in following a response, as well as guiding therapeutic management. And that's the sunset over Clearwater Beach.